Good evening. We would like to welcome you to the PCMH Quality Assurance Program Educational Webinar. My name is Jana Ferguson, and I am with the PCMHQA team. I just want to go over a few housekeeping items before we start today's learning session. Lines will be muted throughout the presentation. Please feel free to use the chat function to ask questions or to enter comments. We will open the lines up during the presentation and end of the presentation for questions. If you did not receive today's slides, use the chat function to enter your name and your email address, and we will forward you a copy of the presentation. Today's webinar is being recorded. I will turn the program over to Chad O'Kane, who is the manager for the PCMHQA program.
Thanks, Anna. I, too, want to welcome you to this session and thank you for taking the time to attend. I trust you'll find the information helpful and useful as you participate in the patient-centered medical home. With me in the room is part of the PCMH Quality Assurance team, including Relinda McFadden, who is a clinical lead for the PCMH Quality Assurance team. With me is Shelley Fetter and Jana Ferguson, from whom we've already heard. She and Jana are two of our PCMH Quality Assurance specialists. Anna already mentioned, please feel free to use the chat box for asking questions throughout the presentation. We will also provide for questions throughout the session with unmuting your line. We are hearing about many transformations that are taking place in your practices and conversations that are happening around care coordination. So I congratulate you on the progress you are already making. To begin our presentation, I want to stress to you that the quality assurance process for the PCMH program is not intended to be punitive. We are to help you be successful in this program. In that vein, if at any time you have questions about the activities or metrics, please contact your AFMC Provider Relations representative who is in touch with our team. We'll work with the AFMC Provider Relations team to get your questions resolved. If there are issues with meeting the activities and metrics, our efforts will focus on helping you be successful. So let's get started with a review of the 6-month activities that are due June 30. The first is to identify your top 10% of high priority patients. Next, to assess operations of practice and opportunities to improve. To strategy to implement care coordination and practice transformation. To try and address medical neighborhood barriers to coordinated care at the practice level. To provide 24/7 access to care. And to document your approach to expanding access to same-day appointments. As you post your 6-month activities in the portal, you'll note that you're asked to document various things. For purposes of validation, we will be reviewing your documentation. In that, we would encourage you to consider maintaining a binder of documentation so you have ready access to it and can organize your documentation for each activity. Documenting your processes, plans, and timelines will also be helpful to you as you onboard new members of your care teams, so we think you'll find this a valuable tool. Complete the attestation of your 6-month activities. Our review process will begin July 1st. We're validating your 6-month activities between July 1 and November 31 this year. We schedule on-site visits with you for the reviews. So what are we looking for? For Activity A, identifying the top 10% of your high-priority beneficiaries, we will be reviewing for completion of the selection of your high-priority beneficiaries as submitted via the provider portal. For you enrolled as of December of last year, you completed this activity at the beginning of April. For those enrolled as of May this year, you complete this activity no later than September 30, 2014. For activity B, assessing of operations of practice and opportunities to improve, we will view the tool along with any resulting summary documentation from the assessment that includes identification of your practice strengths and opportunities to improve. I do want to make note that if you are working with the practice transformation vendor, the assessment you completed for them satisfies this requirement. If you are not working with them, we have included some references to other tools that are available for you to assess your practice in light of the characteristics of a patient-centered medical home. There are many tools available. These are just a few examples. For activity C, develop and record strategies to implement care coordination and practice transformation. We will view your implementation plans and timelines for the achievements of those plans. What you see on this slide is just an example of a plan and a timeline. For activity D, identify and reduce medical neighborhood barriers to coordinated care at the practice level. We will view your documentation of identified barriers and your plans to address those barriers. One example of such a barrier is with coordination between your office and a specialist. One might address such a barrier is through the development of a written agreement with the specialist to whom you refer. For E, make available 24/7 access to care. In our review of this activity, we will perform after-hours calls to verify 24/7 access. In on-site review, we will review documentation of efforts to make after-hours access known to patients. For example, brochures, appointment cards, websites. Perhaps it's a printout from your electronic health record. We will also validate that you have posted the after-hours information on public entries to each site and answering machine greetings. To our AFMC provider relations representative about this tool on best practices for after-hours care. For activity F, tracking of same-day appointment requests, we will view your process for scheduling same-day appointments. The written process for activity will be most beneficial to your staff. We will review a report with at least 5 days of data, 5 days before, 5 days after, showing the availability and use of same-day appointments. This report can consist of screenshots or a copy of 5 days of schedules showing availability and use of same-day appointments. Some of you may be able to generate a report from your electronic health record that provides this information. We also review your process for tracking this. How do you monitor your access versus the demand from your patients for same-day access? How do you monitor your supply of same-day appointments versus the demand of your patients for appointments? Included on slide 16 is a snapshot of an example of a same-day scheduling policy that you might find helpful. That's it for the 6-month activities. We're going to talk about care plans, but before we do that, I want to give you the opportunity to ask any questions specific to those 6-month activities. We're going to mute your lines now, and feel free to ask any questions, or if you post a question on the chat box, we will address that as well. Your lines are now unmuted.
Question in the chat. We have an open door policy for all of our patients. Same-day service is available during business hours. What documentation would you require?
We review your schedule as suggested, but you have some sort of documentation saying that that is your practice or policy for your practice. That would be helpful.
There are questions in the chat at this time.
Are there other questions over the phone?
We have a policy that, and it shows up on our EMR as one, those are same-day appointments. Is that satisfactory?
Yes, ma'am.
Okay, thank you.
You're welcome. Any questions? We're going to place the lines back on mute and continue with the presentation. I do point out that we will be talking about 12-month activities in a later presentation, but to mention as we move into those activities, know that we are working hard to minimize the burden of additional work to your practices by maximizing work you are already doing for programs such as PQRS and or meaningful use. Work you're already doing can be used for validation of work that you're doing for PCMH. May, with regard to care plans, I heard many questions, so I hope you'll find this information helpful. Our clinical lead, Relinda McFadden, to talk with you about care plans. Note that a guide has been provided to you as part of your webinar packet.
Thank you. Good evening, everyone. A is the percentage of high-priority beneficiaries identified in Section 241.000 of your manual. These plans, as contained in the medical record, include documentation of a beneficiary's current problems, plan of care integrating contributions from the healthcare team, including behavioral health professionals, and the beneficiary, instructions for follow-up, and assessment of progress to date. As stated, care plans are 12-month metrics. As we begin our 6-month activity reviews, we will, as a courtesy to you and your practice, review 5 randomly selected care plans from each provider. We evaluate the components contained in this documentation and for evidence of the 4 aspects of the metric. Documentation of current problems. What we're looking for is that each visit related encounter document should include a list of current problems. What should there? A list of their current problems. This is similar to what you're doing for Meaningful Use Stage 1 as a problem list, or Meaningful Use Stage 2 as a view, download, and transmit. Care, integrating contributions from the healthcare team, including behavioral health professionals and from the beneficiary. Visit-related encounter or dated entry into a plan of care flow sheet or EHR template should include entry that clearly summarizes the plan of care for that patient. Ideally, this would be a problem-based detail of the plan of care occurring twice during the 12-month time frame. Assessment of diagnosis from the current problems could include the visit note in the plan section or as a standalone document in a separate care plan template. If using a separate document, ensure the inclusion of the date and then dated each time. Using the plan or an assessment and plan section of notes, you include statements for specific problem-related plan information. For example, follow-up diabetes in 4 months with a repeat A1C. Should include approximate or absolute time in something that is to be followed up on. The bottom line, what are we looking for? What medications were started, continued, reviewed within the documentation. Test procedures that were ordered, what was ordered and why are these test orders. Example would be liver profile ordered to monitor long-term statin use. Referrals or transitions of care, where are they going, why are they going, and the plan for monitoring follow-up. You may also find these after looking at your meaningful use stage 2, view, download, and transmit information within your EHR. Specific EHRs that have been certified for the 2014 criteria. Reasons for follow-up. Documentation mentioned in the visitor encounter, existing future visit that is linked to a problem that is currently under management. Knowing that a patient has a future visit scheduled with a patient educator for diabetes management, this documentation could be contained within a completed assessment and plan that was acceptable, as is evidenced in the chart. So what we're looking for, specific instructions for the patient, identifying when they should follow up, and any special instructions for that follow-up. And of the progress to date, encounter document should contain a problem-based assessment for all problems that are addressed during the visit. This assessment should only utilize coded entries from a recognized coding standard such as ICD-9, ICD-10, or SNOMED. Documentation of the plan of care, EHR activity, telephone encounter, or a care update, progress note update, identifying the course of a specific problem that is being tracked. The problem is not clearly managed in a separate EHR activity, standalone care plan, then the section of the encounter or visit document must clearly state or update the steps of each problem. An example would be type 2 diabetes, improved control after changes in insulin dosing, hypertension, which is at the treatment target, changes in medication. So the line, what are we looking for? I find that each chronic diagnosis listed in the problem list has a related status of that diagnosis, whether chronic, controlled, exacerbated, etc. So looking at your non-compliant patient, if a patient misses a follow-up appointment, the clinic can utilize outreach to follow up with that patient. A note can be used to address this and make the care plan, but contain specific time-framed follow-up and re-engagement instructions for the patient. If the patient is non-compliant and the clinic is utilizing outreach to follow up, there should be documentation showing a good faith effort has been made to re-engage this patient. You can update a care plan outside of the provider of care. A licensed nurse may update the status of the plan, including specific instructions and follow-up. You'll find an example of a care plan in your webinar packet. There are also additional examples for you to review. Now open the lines for questions. Your line open.
I do have a question on the your update, if application or if it is for June 30th, does that mean there's only had to be one update, or are we going back to June 30th of 2013?
That twice a year update for plans is a 12-month metric. We're only going to review during this 6-month time as we're doing reviews of your 6-month activities, help to you toward meeting that, because we've been asked to review care plans from a number of providers. So as we're doing our on-site reviews, we want to provide that for you.
The question is, will you be expecting that care plan to have been updated twice or once?
No, at that time.
Okay. It could be updated in August and then again in November. It could have been updated in January and then in March.
Okay.
So it does need to be in the first 6 months or last 6 months, anytime during the 12-month time frame.
Okay. Another question is the physician who is the PCP, that patient, or if the nurse practitioner sees that patient, is that still counted?
Yes, that still counts.
Thank
So it can be if you have a nurse, an LPN or an RN that's following up with your patient over the phone, that counts as long as the documentation is included that would support that. If a patient returns to your clinic and sees your nurse practitioner and that care plan is updated, then that would count. Patient returns to your clinic and sees another health provider in your clinic and update that care plan. That would be acceptable.
If we identified our patients in April, from July of this year to June of next year to do those 2 updates?
Your 2 updates would be, if you've got this performance year to those updates. We will, because the 12-month activities are due December 31st of the year. So, however, if with you for those 12-month activities begin in the first part of 2015, looking for those 2 updates.
Okay.
So the answer to your question is, if you just defined your patient population in April, then yes, you will still need to have your care plan updates by December 31st.
Okay, thanks.
There are no additional questions in the chat. Are there any additional questions from participants? That is your time this evening, and I'll turn it back over to Chad.
Relinda, we're going to turn your lines back on mute. As we do that, I've asked one of our quality assurance specialists, Shelley, to talk with you about the remediation process. As she shares the process with you, I want to remind you that our goal and validation for this program is to enable you to succeed.
Thank you, Chad. Good evening, everyone. There will be 3 situations in which remediation will occur. The first being if a practice does not complete the attestation by June 30th. The second, if there is no response or an incomplete response to a request for validation documentation. The third, if the practice fails validation. So let's talk about remediation for attestation. So if practice does not complete the attestation, remediation will be initiated following guidelines dictated in Section 243.000 of the PCMH Provider Manual. The Provider Manual is available to you on the Payment Initiative website. You can access it at paymentinitiative.org. The practice must submit an improvement plan within 1 month of the date that a report provides notice that the practice failed to perform on the indicated activities. The The practice must remediate performance before the end of the first full calendar quarter after the date the practice received notice via the provider report that such targets have not been met. To ensure completion of attestation, we will email a standardized improvement plan form to practices in question with a duration of the remediation timeline. Improvement plans can be submitted to us by email, and we will be providing you that email address at a later time. After the remediation period, if the practice has not satisfied completion of attestation, practice will be referred to DMS for termination of practice support. For the remediation for non-response or incomplete response to validation documentation request, the request for documentation is not satisfied within 10 business days, the following remediation process will be initiated. On the 7th business day, we will contact the practice advising a failure to submit requested documentation. The practice will be required to submit requested documentation within 5 business days. If documentation is not received within those 5 business days, initiate a scheduled follow-up visit to secure the documentation and to conduct an on-site review. If at that time the documentation cannot be obtained to complete the validation, the practice will be referred to DMS for termination of practice support. So, remediation for failing validation. Again, if practice fails validation, remediation will be initiated following the guidelines dictated in Section 243.000 of the Provider Manual. So the practice must submit an improvement plan within 1 month of the date the report provides notice that the practice has failed to perform on such indicated activities. With respect to the activities tracked for practice support, this must remediate performance before the end of the first full calendar quarter at the date the practice receives notice of the provider report, again, that the targets have not been met. With respect to the metrics tracked for practice support, this must remediate performance before the end of the second full quarter after the practice has received notice via the provider report that those targets have not been met. For purposes of remediation, performance is measured on the most recent 4 calendar quarters. At the end of the remediation period, if the practice has not satisfactorily remediated performance, the practice will be referred to DMS for termination of practice support.
Thank you for that. We're going to open the lines up for questions, but before we do that, I want to take the opportunity to mention to you one of the 24-month activities regarding electronic health record adoption. If you do not currently have an electronic health record in place, now is the time to begin planning for that. If you need assistance, please feel free to ask your AFMC Provider Relations representative of HIT Arkansas and how they can be of help to you. I'm going to now open the line up for questions. If you have questions about remediation or any general questions about anything we've talked about in the presentation, we welcome those. You're now open.
There are questions in the chat at this time.
One more. Well, I want to thank you for attending today's webinar. I hope you found this information helpful and have had your questions answered. We're sending you a follow-up survey for your feedback regarding this session and would greatly appreciate you taking the time to complete that so we can improve these sessions to make them most meaningful to you. Thank you much and have a great evening.